Bismillahirrahmanirrahim. Welcome everybody. My topic today will be clinical evaluation of hypertension. This is our agenda today. We are going to define what is the normal blood pressure, what is the hypertension, and then in between we have a gray zone, what we call it pre-hypertension. Normal blood pressure defined as blood pressure of 120/80 or maybe lower, while pre-hypertensive phase defined as blood pressure of 120 to 139/80 to 89 millimeter mercury. It is usually a benign condition, but you have to follow and treat them by non-pharmacologic treatment and or drug treatment if it is combined with other risk factors. What is the definition of hypertension? Hypertension is defined as blood pressure of 140/90 millimeter mercury or even greater, not taking any medication. Usually, it increases the risk factors by 2 to 4-fold compared to normal blood pressure. Now we come to types of hypertension. We have isolated systolic hypertension, combined systolic and diastolic hypertension, which can be divided again into primary or idiopathic hypertension and secondary hypertension. What is the definition of isolated systolic hypertension? Usually, this hypertension predominates in elderly population and is defined as systolic blood pressure of 140 with normal diastolic blood pressure or even below than normal. Primary hypertension defined as hypertension without identifiable etiology, and there should be genetic background with environmental factor, while secondary hypertension is due to identifiable and potentially curable etiology, which include renal, endocrine, cardiac, neurogenic, and vasoconstrictor drugs. Renal due to renal parenchymal disease or renovascular hypertension. Endocrinal may be due to pheochromocytoma, acromegaly, hyper and hypofunction of thyroid gland, hyperparathyroidism, and maybe mineralocorticoid hypertension. Neurogenic causes due to increased intracranial tension, cardiac causes due to coarctation of the aorta and polycythemia, toxemia of pregnancy, and drug-related hypertension. The commonest drugs in our Egyptian market are oral contraceptive pills, non-steroidal anti-inflammatory drugs, and sympathomimetics. Other definition you should know about refractory hypertension. It is a high blood pressure not controlled by more than 3 drugs of different mechanisms for more than 1 month. Another definition will be hypertensive crisis. It may include urgency, high blood pressure with no acute target organ damage, and emergency with high blood pressure and acute target organ damage, such as acute left ventricular failure, acute renal failure, papilledema in malignant hypertension, and encephalopathy. Pseudohypertension more common among elderly population and is artifactually elevated blood pressure obtained by indirect cuff measurement over a rigid brachial artery. How can I know that it is a case of pseudohypertension? If I have high blood pressure in elderly population for a very long time without target organ damage, I have to think in pseudohypertension. How can I know that? By investigations as well as invasive and non-invasive methods. White coat hypertension, high blood pressure occurring in clinical setting with a normal daytime ambulatory pressure. It is not a benign condition, and you have to follow them and treating them by non-drug treatment. Masked hypertension is a mirror image of white coat hypertension. Clinic blood pressure is normal, but ambulatory or home measurements are high. Also, it is not a benign condition, and follow-up is mandatory among these patients. Now we will come to hypertensive emergency. It is defined as acute or rapidly deteriorating target organ damage occurring in a hypertensive patient in association with elevated blood pressure. We can classifying them into malignant hypertension with papilledema and accelerated hypertension with hemorrhage and exudates. What are the WHO criteria of malignant hypertension? It includes acute and rapid progression, a very high blood pressure, especially diastolic blood pressure with generalized vascular damage, microangiopathic hemolytic anemia, papilledema. This usually occurs rapidly from acute renal failure, acute heart failure, and brain hemorrhage. Fibrinoid necrosis is the hallmark of the malignant hypertension. Lastly, what is dippers and non-dippers? Normal individuals have circadian variation in the blood pressure. Non-dipper can be diagnosed by ambulatory blood pressure monitoring. It is more common in diabetic, usually associated with left ventricular hypertrophy and more organ damage, and usually hypertension can be due to secondary form of hypertension. Now we'll come to categorization of the blood pressure level. Usually, this is the old classification. Optimal blood pressure with the blood pressure 120/80 or maybe lower. Normal blood pressure 130/85 or lower. High normal with 130 to 139/85 to 89. Hypertension with different grade 1, 2, and 3, and isolated systolic hypertension. Nowadays, this is a very simple classification, including normal blood pressure, 120/80 or maybe lower, pre-hypertension with the 120 to 139/80 to 89, and then hypertension, which include stage 1 and stage 2 of 160/100. What is the magnitude of the problem of hypertension, especially in our Egyptian population? Hypertension is a major problem in Egypt with a prevalence rate of nearly 25% among the adult population. The prevalence increases with aging, and the control rate is very poor, ranging from 8 to 10% in our locality. It is not only a poor control rate in our locality, but also even in developed countries, ranging from 6% to 27% all over the world. Now we come to diagnosis of hypertension. How can I diagnose high blood pressure? If I have persistent elevation of blood pressure, 140/90 or more for 5 repeated measurements in 5 office visits over a period varying from days to months, this can be diagnosing hypertension. The frequency of visits and the periods of blood pressure monitoring is dedicated by the severity of hypertension and risk factor profile. And blood pressure should be measured accurately and under standardized conditions. Now, blood pressure can be measured by in clinic, home measurement. Nowadays, the guidelines recommend home measurement, ambulatory blood pressure monitoring, especially in white coat hypertension. Ambulatory blood pressure monitoring, the 24-hour monitoring of the blood pressure. Today, 24-hour blood pressure control is essential. Identify depart from non-depart, and it excludes white coat hypertension as well as secondary form of hypertension. How can we measure the blood pressure according to the guidelines? Use properly maintained calibrated machine, either mercury manometer or any rod. And the rod should be periodically every 3 months calibrated. Examination done in a quiet room after 5 minutes rest in a relaxed position. Avoid talking for 5 minutes prior to measurement. Measure blood pressure in sitting position, supine, and standing blood pressure, especially in diabetic and the elderly, to exclude postural hypotension. Remove tight clothing and support the arm at the heart level. Ensure hand relaxation. Lower mercury manometer column very slowly, 2 millimeter mercury at a time. You're invited, if needed, no food intake, coffee, or smoking for 2 hours before the procedure. Measure the blood pressure in the right arm while the patient is sitting, back supported, or while lying flat on his back. Appropriate cuff size and palpatory blood pressure measurements are essential before auscultatory method. The appropriate cuff size, one for children and one for the adult, and another for obese individual, and lastly for the measurement of the blood pressure in lower limbs in coarctation of the aorta, large thigh cuff. Take systolic blood pressure at first appearance of sound, and take diastolic blood pressure at complete disappearance of sound, what we call it phase 5. Take the lower value for at least 2 readings. Care must be given to all steps of the procedures. Then, how can I do clinical evaluation from the clinical picture of hypertension, which may be uncomplicated or may be complicated? The uncomplicated hypertension may be with no symptoms at all, or may be symptoms non-specific, such as headache, mainly occipital, dizziness, vertigo, tinnitus, and palpitation. As regards the complication of hypertension, cardiovascular complication, for example, left ventricular hypertrophy and or failure, coronary artery disease, aortic dissection, recurrent epistaxis, maybe cerebral, TIA, encephalopathy, cerebral hemorrhage and infarction, and subarachnoid hemorrhage. And then maybe renal, proteinuria, and nephrosclerosis with renal failure, retinal complication, including different grades of hypertensive retinopathy from grade 1, 2, 3, and 4, in grade 4, papilledema, especially in malignant hypertension. There are situations that require immediate blood pressure reductions by parenteral therapy in an intensive care unit to prevent target organ damage. This situation, we call it hypertensive emergencies. What are these hypertensive emergencies? Acute left ventricular failure with pulmonary edema, aortic dissection, acute myocardial infarction, unstable angina, eclampsia, preeclampsia syndrome, hypertensive encephalopathy, cerebral infarction, and hemorrhage, papilledema, acute oliguric renal failure, and pheochromocytoma. The last item in the topic will be laboratory evaluation. Essential hypertension, unless complicated, is usually asymptomatic. Diagnosis depends upon accurate and repeated measurement of the blood pressure. What is the target of our evaluation? The objective of clinical and laboratory evaluation is establishment of the diagnosis of hypertension, identify other cardiovascular risk factors, evaluation of target organ damage, diagnosis of secondary form of hypertension. What is the value of early recognition of the high blood pressure? We call it a silent killer, and so should be early recognized and diagnosed. Blood pressure level is linearly and continuously related to the risk of cardiovascular diseases. The target organ damage occurs early in the hypertension, and hypertension commonly occurs in association with other risk factors, which interact synergistically to multiply cardiovascular risk. For that reason, early recognition of the high blood pressure is mandatory. Medical history. In most of the patients with uncomplicated hypertension, usually no significant symptoms. Physicians should inquire about previous level of the high blood pressure with or without treatment, symptoms of target organ damage, symptoms suggestive of secondary form of hypertension. Also, the doctor or physician should inquire about current medications, comorbid conditions, positive family history, and lifestyle factors, including salt intake, fat intake, smoking, physical inactivity, alcohol, and drug abuse. And then we'll come to general examination in hypertensive patient. Establish the diagnosis of blood pressure by using proper measurement procedure and following the guidelines. And then peripheral pulsation should be palpated. Document that the femoral pulsation are not delayed beyond the radial pulsation. Body weight and height and body mass index should be checked. And then waist circumference should be recorded and search for neck bruit. And then we'll come to local cardiac examination, searching for left ventricular hypertrophy, gallop, and ejection murmur over the aortic area, and carefully look for aortic murmur. Abdominal examination for renal enlargement, abdominal aortic aneurysm, and renal bruit. Chest examination for COPD, neurological examination, searching for the level of consciousness, speech, motor power, lateralization, and others. If you have profound muscle weakness with intact sensory function in a hypertensive patient, you should suspect primary hyperaldosteronism. This is an example of hypertrophied myocardium in a patient with hypertension compared to a patient with normal blood pressure. This is a cross-section in the myocardium showing left ventricular hypertrophy compared to normal blood pressure. This is an echocardiography with left ventricular hypertrophy compared to the patient with normal blood pressure. An electrocardiography showing left ventricular hypertrophy in hypertensive patients by voltage criteria. Chest X-ray with cardiomegaly due to left ventricular hypertrophy in hypertensive patients. Optic fundi should be examined whenever possible and usually in all patients with severe or resistant hypertension. Clinical examinations should also include searching for underlying etiology of the hypertension if it is suspected. And when hypertension is difficult to control in spite of triple drug treatment, or if it is severe or sudden onset, particularly in young population, or above the age of 60 years, or if there is rapid deterioration of kidney function. Referral to specialized doctor is needed in these situations. Search for target organ damage, which include left ventricular hypertrophy, either by clinical manifestations, by electrocardiography or by echocardiography, heart failure, by clinical picture, coronary artery disease, searching for anginal pain, acute myocardial infarction, and history of intervention and or CABG, renal disease, serum creatinine, proteinuria, and cerebrovascular, such as transient ischemic attack and dementia and old stroke, peripheral arterial disease, abdominal aortic aneurysm, and more than grade 1 optic fundus retinopathy. What is ankle brachial index? Ankle brachial index is a simple non-invasive test to diagnose peripheral arterial disease. Normally it is 1 or more than 1. If it is 0.9, it indicates peripheral arterial disease, and it is correlated with angiography. And if it is from 0.5 to 84, it correlates with intermittent claudication. If it is 0.5 or lower than that, it indicates advanced lower limb ischemia. Risk categorization for patients with hypertension. Hypertensive patient can be categorized according to risk profile into low, intermediate, and high risk. Low risk with no target organ damage and no other risk factors and no associated cardiovascular disease. In Group B, intermediate, one or more additional risk factors, but not diabetes or target organ damage. And then high risk target organ damage and or associated cardiovascular disease. We have to make assessment for prognosis. Prognosis in hypertensive patients is highly variable, depending largely on factors other than blood pressure, such as gender, age, other risk factors, target organ damage, or history of cardiovascular disease. Among these factors will be male gender, elderly population, more than 65, current smoking, diabetes, dyslipidemia, and positive family history. Laboratory evaluation. What is the standard optimal care? Just urine analysis for any microalbuminuria or macroalbuminuria, serum potassium and creatinine level, uric acid, blood sugar, lipid profile, and standard 12-lead electrocardiography. The minimum evaluation care will be urine, electrocardiography, fasting, and postprandial blood sugar. What are the optimal laboratory tests? More extensive investigations are indicated in the following conditions. When secondary forms of hypertension are suspected. To determine the significance of borderline hypertension while screening the target organ damage, and when symptoms are suggestive of target organ damage. These highly extensive investigations include echocardiography, abdominal and peripheral ultrasound, carotid ultrasound, testing for microalbuminuria, ambulatory blood pressure monitoring, and usually put in consideration the goal-oriented testing for suspected secondary form of hypertension or hypertensive complication. Thank you.